Welcome to the NICU Radiology Casebook series. Upon completion of this module, clinicians will be able to identify respiratory distress in an infant, formulate a differential diagnosis for respiratory distress based on the clinical information available, interpret a chest X-ray and fluoroscopic study, plan appropriate medical interventions. Case 2 is a case of respiratory distress in a 4-day-old term infant with a suspected anatomical anomaly. Our patient is a 4-day-old term infant who was transferred from the nursery to the NICU for evaluation of desaturation spells. The infant was born to a 30-year-old G6P2 now 3 mother with prenatal labs, blood type O positive, antibody negative, GBS positive with otherwise unremarkable screens. Maternal history was notable for a previous caesarean section and VBAC delivery, history of a positive PPD screen with negative chest X-ray, and history of hepatitis B carrier state. Prenatal ultrasound was notable for a left ventricular echogenic focus and mild bilateral pelviectasis, both of which resolved upon follow-up ultrasound. His family was seen by a genetic counsellor, however amniocentesis was declined. Prenatal course was notable for isolated proteinuria without preeclampsia. The infant was delivered by repeat caesarean section with rupture of membranes at the time of delivery. There were no sepsis risk factors. APGARs were 9 at 1 minute and 9 at 5 minutes. Postnatally, the infant was noted to have repeated episodes of duskiness, coughing and sputtering with feeds in association with desaturation. He was therefore made NPO and transferred to the NICU for further evaluation. His admission physical examination was notable for mild respiratory distress with tachypnea and mild intercostal retractions. He also had bilateral polydactyly with well-perfused pink hypoplastic digits connected by a thin stalk. Here is his admission chest X-ray. What are your findings? What is your differential diagnosis at this time? What additional tests might you order to help confirm your diagnosis? Please pause the presentation while you answer the following questions. This is a portable AP chest X-ray of our patient with correct right-left orientation. The film is mildly rotated as can be seen by the asymmetric positioning of the clavicles and the ribs. The NG tube is in place with the tip terminating in the stomach. The thymus is noted particularly on the right with mild indentation where it comes in contact with the ribs. Due to the degree of rotation and the presence of the thymus, the cardiac silhouette appears artifactually displaced to the right. The lungs are well expanded with 9 posterior ribs visible. There is some opacification in the right upper lobe suggestive more of aspiration than of atelectasis, as there is no apparent loss of lung volume. Oral bedside nasoendoscopy was negative. A contrast esophagogram was performed. This is a modified contrast study which is performed by a speech pathologist. The infant is given a small amount of thin liquid contrast from a bottle, initially in the upright seated position and subsequently in the side-lying position on a fluoroscopy table. After several swallows, a large amount of contrast was seen in the trachea, which appears to arise from below, suggestive of either massive gastroesophageal reflux or from an H-type tracheoesophageal fistula. Contrast is also seen in the more distal airways. The position of the H-type tracheoesophageal fistula is easily visible here in the side-lying, right-side-down decubitus position, approximately halfway between the thoracic inlet and carina, or 1 to 2 vertebral bodies in length above the carina, lower than typically seen. Throughout the study, the patient remained stable. Esophageal atresia is a congenital abnormality where there is failure of correct embryological development of the primitive foregut into an esophagus and trachea. At least 85% of infants with esophageal atresia also have a tracheoesophageal fistula. Tracheoesophageal fistula without esophageal atresia is also known as an H-type fistula. it is extremely rare, occurring in about 4% of cases. This usually presents after the neonatal period with a history of recurrent pneumonia or respiratory distress, which is temporally related to oral feeding. It can be demonstrated by administration of a non-ionic water-soluble contrast medium during cine fluoroscopy. Definitive diagnosis is with combined fibre optic bronchoscopy and esophagoscopy, with passage of a fine balloon catheter from the trachea to the esophagus. H-type fistulas are usually high in the trachea in the cervical area. Our patient's case is a little atypical, as his tracheoesophageal fistula is anatomically positioned lower than normal, and he also presented early in his clinical course. The infant underwent surgical repair of the tracheoesophageal fistula with ligation and also excision of the bilateral supernumerary digits. During his hospital stay, he was evaluated for Vater association. This is an acronym for conditions that often occur together. The letters stand for V. Vertebral anomalies, A. Imperforate anus, C. Cardiac defects, T. Tracheoesophageal fistula, E. Esophageal atresia, R. Renal dysplasia or anomalies, and L. Limb anomalies. Our infant had normal spinal X-rays and sonography, a structurally normal heart and echocardiography, an H-type tracheoesophageal fistula on contrast esophagogram, mild left hydronephrosis and mild left pelviectasis on renal ultrasound, and bilateral polydactyly without radial abnormalities. He was discharged home from the NICU at 5 weeks of age after his postoperative recovery. Please review the following screen to make sure that you have achieved all of your learning objectives.